Good evening, everybody. This is Dr. Kaladevi. I'm the zonal medical head for the southern region in Dr. Agarwal's eye hospitals. First of all, welcome to the session organized by the Education Board, and a special thanks to Preethi for giving me this opportunity to moderate the session with the great surgeon, Dr. Jeevan Singh Titiyal, sir. As you all know, he is the former chief of Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIMS, New Delhi. Now he is currently designated as regional head of Dr. Agarwal's eye hospitals, Delhi. He is a professor of ophthalmology with expertise in cataract surgery, corneal transplantation, and refractive procedures. He is a pioneer in femtosecond laser assisted cataract surgery, phacoemulsification, eye banking, and corneal disorders. Over 400 publications he has and 70 plus book chapters. He is the first Indian to perform live surgery at ASCRS annual meeting and invited faculty for 200 international and national conferences. He is a recipient of Padma Shri Award for the outstanding contributions in ophthalmology, honored with multiple national and international awards, including the APO Distinguished Service Award, AAOS International Heroes Award. Above all, he is a passionate teacher, actively training undergraduates, postgraduates, nursing, and optometry students, along with ophthalmic surgeons. A good surgeon operates with your hands, but a great surgeon operates with your heart. The best surgeons know not only how to operate, but when not to. So, this is a controversial topic like maximizing the outcomes of toric IOLs, which case to touch and what case to correct. So, we have a great surgeon, Dr. Jeevan S. Titiyal, who is giving us his hints on how to maximize the outcomes in toric IOL. All to you, sir.
Very good evening to all of you, and thank you, Dr. Kalla, for a introduction. I think
Yes.
it is not important. It important is how we conduct this particular webinar today. I'd like to thank Dr.
Yes,
Preethi
yes.
for getting this topic to all of us. I think there's not much a controversy. It is a subject which has to be dealt in a manner where the outcome improves for all patients. So let me take you through today's presentation of mine, where I'm going to outline this presentation into six segments. The initial indications for a toric IOL implantation, proper patient selection, pre-op investigations, and a little bit of surgical techniques and difficult situations, and most importantly, for a post-op assessment of these patients with toric IOLs. I have no financial disclosure to be made for this particular talk, and this is one review article we published in IGO way back in 2000. I think it was 2000, way back, and it still holds true. People can go through this, and where things can, really change. This particular slide I've shown here because you do have options of managing the pre-existing astigmatism along with the cataract surgery. And one of them can be a toric IOLs, but other measures people have done like arcuate keratotomy, limbal relaxing incisions, modifying their incisions. But best option will be toric IOLs per se, because it is the procedure of choice, because single setup and the comfort perfectly, as routine cataract patient undergo, much more predictable than any corneal procedure. Let it be with the diamond knife, with the laser assisted procedure. Nothing can challenge the outcome with toric IOLs in these patients. And three important things should be how to get a proper patient. And I'm pretty sure biometry is one of the most important aspects for any cataract surgery and holds true for a toric IOLs also. Therefore, the calculation of IOL power is of utmost importance, where we look for a refractive cataract surgery. Because toric IOLs has made that change in our cataract surgery patients, where we can do a refractive correction for all our patients. And that is what I'm going to deal today. And looking at indication wise, you all know any astigmatism which is significant enough, maybe a more than 1.25 diopter of corneal astigmatism, because it is not the total astigmatism. We are trying to correct the corneal astigmatism. Therefore, we need to really do a good assessment of a corneal toricity for these patients also. Sometimes the history also is also helpful of glasses used by patient, and that also tells you which type of astigmatism patient may be having. And before that, we need to understand the range of toric IOLs available now. We have a range which may range from 0.75 diopter to a large diopters now, and it all can be customized. That is most important part. These lenses can be customized now of a requirement for a patient. Let's see, once we consider more than one diopter, maybe a case where toric IOLs can be considered. Which are those cases where you may have a poor outcome of toric IOLs? because all routine cases are we can always implant where you have a regular astigmatism. So if you have a irregular astigmatism, corneal scar, a patient who has corneal ectasia where toric IOL in outcome may not be as great as normal patients, patient with associated problems like a glaucoma, drainage surgeries, prior vitreoretina procedures, poor pupillary dilatation, or you have a post intraoperative complications like a jonular dialysis or a posterior capsular dehiscence. So these patients can have a very unstable IOL placement and maybe a poor candidate for these patients also. But most important part for assessment for our patient is to check the ocular surface, because that is one which can really, change the corneal astigmatism. If patient has the ocular surface disorder or a dry eye condition, it is always better to treat that first, then go for an actual assessment, then think of implanting toric IOL in these cases also. Let me give you a case scenario one. You can see a patient, 62-year-old patient, left eye came for a monofocal IOL implantation. We did a biometry for this patient. You can see the total astigmatism is 2.41 diopters. So this patient, even after implanting simple monofocal lens, patient will not be happy in the post-op period because it will have a huge residual astigmatism where the patient visual quality, unaided visual quality may not be good in these cases. So this is how we need to counsel this patient. You have a large degree of astigmatism, which cannot be corrected by simple cataract surgery and implantation of monofocal IOL. You require a toric IOL implantation per se. This is another patient. Patient come for a premium IOL, multi-trifocal IOL. We did a biometry in this patient. The patient has 0.76 diopter astigmatism, the TK. So if you consider one diopter as a cutoff, you'll say, okay, this patient is all right, less than one diopter. But it is important to understand if you are going for a multifocal, trifocal lenses, even this small number of astigmatism needs to be corrected. Otherwise, patient will never be satisfied in a post-op uncorrected visual acuity gain in these patients also. You can say this patient required a T3 uh, implantation of toric IOL, and you can residual astigmatism is just 0.03 degree diopters. So this is the importance of doing a good biometry for these patients, which will give us the assessment. The biometry should be one investigation in cataract patient should be done in a virgin eye. That means whatever investigation you have to do, it should be done after you do a biometry so that your corneal surface is not touched. And that is important for all of us to know. And optical biometry is one which is very, very important for us. I have all talked about counseling per se. Counseling is important for all patients. After doing biometry, getting the requirement for these patients, the paying capacity sometimes may be hindrance for these patients because these toric IOLs always add into IOL, you can say, cost, which I always been debating with the companies not to have a higher cost of toric IOL because they have become like a mandatory part of a toric IOL design. So it should not be getting, little more expensive to patient per se. While investigation, I talked about ocular surface, TL film status, look for a grade of cataract, rule out any other pathology which may be a cause of poor outcome for these patients. Stabilize the ocular surface, do biometry, and look for IOL power calculation, which is going to give a best outcome in your hand. That means you need to do large number of cases, understand what is your constant for your calculation, and take that formula for these group of patients also. One thing is very important. Axial length, I said, optical biometry will give you a absolutely correct assessment of axial length. Those cases where you can't do optical biometry, the other best method would be a immersion biometry for these patients. Most important part is to check for a keratometric values or the power of cylinder on the corneal surface. And apart from the power, axis is also very, very important. You may have to use one or two instrumentation to check this power and axis. If axis is similar with the two or three instrumentations, this patient would have a regular astigmatism. Your axis is deviation by more than 7 to 10 degrees at 2-3 instrumentation. Patient may have either the dry eye features or poor ocular surface, or patient may have an irregular astigmatism. So these patients, you have to be little careful. Maybe you treat ocular surface and do a assessment again in these patients also. If you have manual or automated keratometers, any device you use should be calibrated so that you get a good outcome for these patients also. So if you have optical coherence-based systems, which can give you a nice posterior corneal assessment also, which is very, very important nowadays, especially for where we go for a trifocal or a new generation monofocal lenses as such. To enhance your accuracy in keratometry is very, very important. As I said, use 2 or 3 different instrumentation with different principles and check the keratometric values. Biometry, make sure your alignment is correct. If you see this picture here, there's a tilt here. So once you have a tilt, it's not hitting the foveal area. And you can see the corneal pictures are also not very good in these cases. It is eccentric, patient not fixing well. So patient's cooperation is also important when you are doing a biometry. Patients should fix well so that you get the correct orientation and correct picture. If you take this scan, you are sure you're going to get a large cylinder, this patient, as you say, 2.25 is a cylinder. If you do it again with the correct orientation, patient doesn't have the cylindrical power. Patient requires a simple monofocal lens. So this, your technician or optometrist should look into this, need to have a proper fixation by patient also to get a good reading. Ask patient to blink, make sure you have a good reading from optical biometer. So this you see, these are keratometric Myers onto the surface. By this only you can judge if your tear film is all right or not. So this can be picked up by your technician that, sir, madam, this patient has a poor ocular surface. So that is also very important. You can have a macular scan with you also and check the macular pathology in these cases also. Make sure you rule out other causes of toricity, which may be points which can change, like this patient has a scar in the periphery, which can be a cause for a significant corneal astigmatism. But if it is a stable one, you repeat in the 2-3 instrumentation, 2-3 sittings, you can still implant the toric IOLs also. But if you have a patient with a significant astigmatism because of pterygium, the pterygium surgery has to be done first. Make sure your corneal surface is regular, then do a surgery for these patients also. Like this patient, you can see after surgery, this has almost corrected after surgery. You can see hardly any cylinder remaining after surgery also. And this becomes a good case for subsequent implantation. Let me give you a little brief on a corneal, posterior corneal astigmatism, because this is an important consideration now. People talk about this, but luckily we have instrumentation which takes care of this assessment and gives a TK value, which may be important. But those instrumentation where you can't assess the posterior corneal curvature, so this has to be understood. We always know the anterior corneal curvature is always a spherical. It can be with the rule or against the rule, and it keeps shifting towards the with the rule to against the rule as the age advances. While the corneal posterior corneal curvature is always, you can see it's little concave. There's a minus lens from posterior side, which normally remains stable against the rule. You can understand if posterior is against the rule, anterior is with the rule, or anterior against a rule, these two will have a different reading of a total corneal astigmatism. If both are against the rule, you're going to add. If one is with the rule, anterior, and the posterior against the rule, is going to decrease the astigmatism. So that part needs to be assessed for your patients. And this is the factor which can give you overcorrection or undercorrection for these patients also. As I said, patient has a with the rule astigmatism anteriorly, we are always going to overcorrect these patients. If patient has against the rule astigmatism, which is normally there in our cataract patient at this age group, we are always going to undercorrect. So this particular thing has to be kept in mind in those cases where you can't get the TK value for your cases also. Let's see this case scenario. If you look into this, if you just see the anterior curvature wise, it is 0.89. If this patient goes a monofocal lens, you might avoid this. But if you see TK value, because both are against the rule, actual requirement is 1.18 diopters. So this is the significance of knowing the both anterior and posterior corneal curvature of these patients, which is very significant in a patient where you're going to trifocal lens. Like you see here, if you just consider anterior only, you're going to put T3 in this patient. But if you see the TK value, you require T4. And that is where your residual astigmatism is going to decrease in these patients. From 0.55 diopters, it becomes 0.02 diopters. And that is the importance, especially in cases with trifocal implantation of these patients also. So these are various principles of measuring the corneal curvature posteriorly, and nothing better than instrumentation, which is OCT based nowadays, which gives you a very nice assessment of a posterior corneal curvature. The posterior corneal curvature or TK may be more important Apart from the trifocal or a multifocal lenses, like post-refractive surgery eyes or patient with ectasia, becomes a very important aspect. These are various instrumentation by where you can measure. Other important thing is, knowing the recent generation optical biometers, where you have advantage not only getting a good assessment of entire biometry of your eye, right from the TF film to the fovea, as well as getting a good posterior corneal curvature. And all the modern generation IOL formulas are with attached to these equipment, and that makes life simpler for all of us. Calculation wise, any IOL formula which looks into these three or four important areas. If that we talked about the magnitude of a toricity in the cornea and its axis. Second is a surgically induced astigmatism, which may be significant if your incision size is more than 2.4 or 2.6. Posterior corneal astigmatism, and most importantly, the effective lens position. The formula should incorporate these things, and if you are AI-based systems, which are incorporated now in the newer generation formula, that will give you a better analysis. Other option can be in intraoperative aberrometry that can also assess the aphakic refraction after you take out the cataract, and that also gives you assessment of IOL power and access to be implanted. In fact, after you implant that particular IOL, you can check if your IOL is correctly oriented or not, because it gives you the correctness of placement as well as the residual astigmatism in these cases also. The only problem with these devices is it requires the inventory of lenses to be placed and to be, you can say, assessed in these patients. So this was a pre-op summary of my presentation. Let's see what are the things I will discuss here. The first thing was when to implant toric IOLs. As I said, anything more than one diopter for a monofocal lenses. For a multifocal, trifocal, even up to 0.75, you need to go for toric IOL for these patients also. To determine the magnitude and axis, I talked about devices which can take both anterior and posterior curvature, multiple readings, more than one device. Most accurate combination would be a keratometry with OCT data. IOL power calculation, I think I stress on devices which can have the effective lens position into consideration apart from the surgically induced astigmatism and the posterior corneal curvature. Anything which also has AI-based systems, which is going to be a norm for future, it is always going to be better. You can always log into www.ascrs.org that can give you the various formula. The second part is which type of designs are important to be implanting these lenses, because designs are going to make a difference in terms of the rotation or of the significant stability of these lenses. So any design which can have a lesser significant rotation would be good. Normally, if you see that all these lenses has range from a 1.5 to 6 diopter. Now we have the 0.75 to 4.75 diopter with the standard IOS. But that said, you can have a smart toric lenses, customized can be done. And these lenses can be placed always 180 degree, and it takes the consideration of axis before it manufactured. Otherwise, we have to always place a lens in the steeper axis of a corneal astigmatism. These are various designs which are available. I can say if you have, as I talked about, multifocal, EDOF, monofocal plus, then we have to really correct as much possible as cylinder in these cases also. Surgery-wise, it's quite simple. There's no fear of doing anything extra. It's the same surgery. Only thing, the lens has to be placed in a proper axis, which you have calculated or got it through various investigations. So first, we need to measure the astigmatic axis, that is a steeper axis. Then mark the axis in the eye, which can be a reference axis, then actual placement axis in these cases also. So you have manual marking systems, you have image guided systems like Callisto and Varion. Then as I told, you can have intra aberrometries, hollows, aura, which can again give you the idea to place lens in a proper axis. So these are various manual marking systems which people have been using. And classically, I think people use slit-lamp methods nowadays. But I normally feel comfortable if you have this bubble marker, which gives you a nice 6 o'clock and 180 degree placement, 3 marks. If you have 3 marks, then subsequent orientation of axis marking becomes easier. And sometimes what I do, I can place the central mark in these cases, like here, 6 o'clock. Then this gives a reference for placing the inferior marker, which gives you absolutely parallel marking into the eye, 180 degrees. So 6 o'clock or a perpendicular marking is also very important, which gives you an idea that you are correctly placed in a both horizontal and vertical axis also. These are various studies where compared various manual marking, and they realized that all of them are quite accurate, but it is your experience which is going to make accuracy much important. I would suggest the younger people to practice themselves. Make sure your the placement of markers are significantly correct in always. But if you have the various other devices which can give you a better marking system, that is going to help us. Alignment, as I said, three-step procedure versus image-guided modalities. People have used both of them. The visual quality is to be assessed. Otherwise, if you look into a poster visual acuity wise, even there's a little bit of rotation, the acuity doesn't get disrupted in a simple monofocal IOLs. So these image-guided systems are going to help you in getting a good orientation, because it takes care of because normally investigations are done in a sitting position. What you are doing surgery in a lying position, supine position. So there will be some sort of intorsion or extortion happening in these cases. Therefore, anatomical markings or anatomical pictures taken by the image guided system going to give us a better orientation for a perfect alignment of these cases also. This, many people don't have access to this. When I was in RP center, we had this. So this also gives you a little more variety to make sure in difficult cases, especially post-refractive patients, this is a good device. So these are basic steps of surgical areas where if you see, this is the image-guided system where you have the orientation for incision. One thing is important in toric IOL is you should always place your incision every time in the same area, so that you know that your surgically induced astigmatism will be similar for all cases. Do not change your incision as per the steeper axis of corneal astigmatism, because we are correcting the astigmatism by implantation of toric IOS. So you need to have a good rexis done so that you have a good lens orientation in the bag, because effective lens position is very, very important for these patients. Make sure you don't disrupt the anatomical important membranes, that is a posterior capsule or a corneal endothelial damage, and place the lens effectively. The viscoelastic, if you use, should be removed from both behind the IOL and anterior to IOL. Make sure entire viscoelastic removed, and the lens should open up completely. Sometimes the lens may not be opening correctly, and that may be a cause for a post-op rotation of these patients also. So you can see we get the three lines. So you should orient this three dots which are near optic junction to be aligned with the central line of these cases also. And that is how these good. And towards the end, once you hydrate, tap your lens in the bag so that it remains perfectly aligned in these cases also. So this is how the surgery is done. It is not different than any other surgeries. Manual surgery can also be done. This is a small trick for all these cases. After, especially these open loop haptics lenses are difficult to rotate anti-clockwise. They're easy to rotate clockwise. So make sure we place the lens little. If you see at this, I was correctly oriented here. So I did a hydration. During the hydration, lens shifted. You can say it is gone anti-clockwise of 5 degrees. Now I'll have to rotate entire 180 degrees to come back to this. If I would have left little anti-clockwise, the rotation would have been simpler. So this is a little trick in these open loop haptics. Don't let lens go over the line, otherwise it becomes difficult to rotate backwards. So this is a manual marking. You can see if I go back a little bit to show that how it is done. So we have these three markings here, 6 o'clock, 180 degrees, and this is a ACS toric marker. Take the most important part is when you mark, it has to be sharp and thin. If you're very thick marking, that things become very, very, fuzzy and difficult to orient your lens. You can see how sharp are my markings here, and this makes placement much easier also. So this is one study we published long time back where we compared the outcome of toric IOL surgeries using the bubble marker as a manual device and the image guided system. And to check the not only the visual acuity, we want to check the visual quality by assessing their MTF values, and that gives a much better orientation. You can see if you use the manual marker, the deviation is around 5.8 degrees plus minus 370. If you use an image guided, deviation less than 4 degrees in these cases, which was significant in this group. The MTF values and the point square functions were far better in image guided systems because the accuracy was much better. So if you have a better orientation, lesser rotation from the main axis, you get a better quality of vision, and it is definitely much better in cases with multifocal IOS. This is a one femtosecond laser device where it gives you the capsulotomy area, which is aligned with the toric axis. The implant has become very simple because on the table only you can align your lens. So this gives a little knob here. When you actually we are doing the, you can see this knob while planning the capsular axis. And this gives you a orientation for your implantation. So this is the knob here. I'll rotate the lens to proper axis, and we checked with the image guided system also. It was very accurately placed. And if you have these devices, you may not require the image guided system or a manual marking in these cases also. The outcome was quite accurate. So this was the second aspect, the surgical aspect, where we talked about the methods of putting the markings, reference marking into the corneal limbus, and looking for other devices, image guided system, which will be definitely better by giving a more accuracy of placement of lens, and also improve the visual quality of these patients also. If you have intraoperative abrometry or type of devices, which may be valuable in some difficult cases where pre-op assessment or readings are not very reliable, these cases may be good in these cases also. Nowadays, we look for a digital workflow where system becomes very, very simple. Like I have a pre-op data from IL Master 700 or ray tracing abrometry. That data is incorporated and transferred into operating microscope, where you have the Callisto attachment, which gives an automatic alignment of the image taken by microscope. You place the surgery. If you have a 3D heads-up device, things become much simpler. And this same data can be taken back to the your pre-op investigation area in ray tracing abrometry, and that can tell you the post-op alignment for your lenses also. So this is what I routinely use, the 3D heads-up device for doing surgery. And the important thing here, you are seeing the large screen. There, these three lines become very narrow compared to the microscope where the three lines are little more broader. So your placement becomes more precise when you use the 3D headset devices as such. Little bit on a difficult situation of a surgery. I'd like to show you three videos where we assess. Small pupil, the small pupil can be challenging sometimes, extended rhexis or a posterior capsular rupture. These are three areas where your surgical plan can go haywire. So if you're a small pupil, make sure you increase the visibility of doing your proper rhexis. So don't delay your enlargement of a surgical area in these toric IOL because you have to have a good rhexis orientation. And when you implant the lens, your all those three markers should be visible in these cases. So I normally suggest pupil expander for these patients and do surgery comfortably. If your rhexis is extended, the anterior rhexis, and luckily if it is away from your toric axis implantation, you can still go ahead. But your axis is totally broken in the same axis where the lens has to be implanted, either side, then these can be challenging cases, especially in a post-op rotation wise. So you have to be little careful in these patients assessing the post-op period. If there's a rotation in these cases, wait for at least 1 or 2 weeks before reorientation of these lenses. Because by the time there will be a little fibrosis and your re-rotation will be more satisfactory in these cases. While the posterior capsular rupture cases, if you have the intact anterior capsular rhexis, then you can try for reverse optic capture in these cases, or sometimes you may have to go for other ways to implant lenses, especially putting a lens in sulcus. Then it becomes a difficult scenario for assess. Little bit of post-op rotation, that is my last segment, where we know that IOL rotation is a major challenge for us, especially toric IOLs. But it is very important to know it's a very significant less amount of cases where you may require to intervene. Large number of patients you don't have to do anything. It's a very safe procedure. The two or three simple. One is the pre-op factors, which may be the cause, or intra-op or a post-op factors. Pre-op when you have done an inaccurate axis calculation. Intra-op when, as I said, your axis marking was incorrect, your placements are incorrect, or you left a lot of viscoelastic inside the eye. Posterior rotations are quite rare. It normally happens in those cases where you have the bag may not be as suitable, like a large capsular bag in high myopes, or patient with a very shallow anterior chamber, where your effective lens position can be challenging, or patient had the general dialysis. These are cases where you can have a posterior rotation. This is one Japanese study where they talked about maximum rotation happens with the first hour of surgery. And as far as we are concerned, we don't check in the first hour for these patients. Patients go after surgery, they come back next day only. But this may be important factor in those cases where you use a lot of viscoelastic. Nowadays, many people have shifted non-viscoelastic placement IOLs. Those are hydroimplantation. So this viscoelastic related problem may not be there in these cases also. These are a important issue to be discussed here, because it's not only the capsular bag, the relationship of material and design with the capsular bag is important. So if you have hydrophobic acrylic lens, more stable than a hydrophilic, and if you have a loop haptic IOLs, they are more stable than a plate haptic lenses. And in terms of posterior rotation, again, loop haptic IOLs are better than a plate haptic lenses. So this is a little bit of this thing. You all understand that designs make a huge difference in our posterior rotation. And this is the, I think the study was quite old, 2015 study. Acrysoft lenses had a less than 2% rotation of posterior period, while Technics had around 3% rotation. But now we have a Technics 2 with little modification in the haptic, which has become little textured haptic. The rotation has decreased less than now Acrysoft lenses, it is less than 1% in these cases. Silicon lenses had a higher rotation. But effectively, it is less than 3.3% in a large series of cases, which is, I think, very less cases where you require intervention. Even these cases also may not require intervention. In my experience, less than 0.2% require intervention or surgery. Which are those cases where you like to intervene? I think this is a very simple way to understand in all toric IOL patients. Whenever we look into a spherical equivalent power post-op refraction, it is more than the cylindrical error. So this patient may help by rotation. If your cylindrical error is more than the spherical equivalent, so this rotation may not help. Simple example is if I have this minus 2.5 spherical with one diopter cylinder. So spherical equivalent to diopter in this case, cylinder is only one diopter. So this patient rotation will not help because your calculation has become haywire in this patient, the spherical power. But this case, if you see the spherical equivalent 0.5 diopter, but cylinder is 1.5 diopter. So this patient is definitely going to benefit by rotation post-op period also. This is a simple analysis for your patient before getting into a various ways. So what normally we do, you assess the visual acuity, uncorrected visual acuity, which is less. Then we do a refraction to see what is the amount of refractive error patient has. Third thing is, dilate the pupil completely. See these orientation lines and see in a straight line how far away from your initial axis of a corneal steep axis is. Accordingly, that amount of rotation may be required. So it is the assessment of visual acuity, the posterior refraction, and the checking the alignment of these toric IOLs, which may be important. You can go to online formulas, online ways to check. That is www.astigmatismfix.com, which talks of same thing, the placement of IOL post-op, where it is placed, what are the initial placement needed, and what is the refractive in these patients also. So if you see this patient, the planned axis was 85 degree. The current axis is 100 degrees. So it is almost 15 degrees away. And you see here, spherical power is 0.5 diopters and cylinder is 1.5 diopters. So definitely this patient is going to benefit. So this tells us that, this patient would require a rotation from originally 85, now it is 100. The rotation will get back the cylinder amount and it will be absolutely correctable. So this is what has happened. It tells you that now the ideal position toric IOL should have been 88 diopters, and the residual astigmatism will decrease to from 3.60 to 0.21, and this is how it gives you beforehand, and you become quite comfortable. So this 12-degree rotation clockwise is needed for this patient, and this will give you from 3.38 cylinder to 0.21 cylinder. Same thing can be assessed by other means also. So this is a eye trace, which normally Tracy technology also tells you in a toric post-op enhancement software. it tells you that this patient require a 26-degree rotation. If you have this red refraction, 0.37, 1.7 diopter cylinder, red is always requires a correction. If this would have been green, the patient vision would have been all right. So this tells you there's a rotation of 26-degree will give you a 1.56 diopter change, and then magnitude will come down to a less than 0.3, 0.26 diopter in a post-op period. And this gives you a, after rotation, the patient would require a good correction. So after rotation, it tells you that green refraction, 1 degree rotation, and 0 diopter change in a cylindrical power. So this is how technology helps you in calculation of how much power, how much rotation is required, and what will be a post-op outcome for these patients. Also, if you don't have these instruments, then you can go for an online assessment by checking the three important things which we talked about. So we checked for IOL alignment by various technologies after full dilatation. Islam method, you can do a photographic technology, use a smartphone softwares, ray tracing technology to check how much alignment is required. Which are those cases? If you have alignment more than 10 degrees and visual acuity less than by 6/9, and patient is very unhappy. If sometimes patients are quite happy with this in a simple monofocal toric lenses, you don't have to intervene every case. The patient's requirement, patient demand should also be taken into consideration before you try to rotate these patients. So we understand anything more than 10 degrees, the visual quality will be very poor, acuity will be poor. These patients as well will demand, and you can take them patient for rotation. So this is what we talked about. We look for these two formula. If you have a Tracy system, you can always know the technology wise, or you check the misalignment, refractive error, go to astigmaticfix.com. It tells you how much rotation you require. And third thing is, when to do it within a first week of your surgery, best time, and especially in those cases where you had a good placement, a post-op it has rotated. Those, as I said, maybe high myopic patient where you might have to rotate little more time than a normal 1 week. Within a first month is also all right for these patients also. So this is our, I think, review article which came up in 2018. People can go through this. It covers all entirely how to deal with astigmatism for these patients also. I think this covers the entire range of toric IOL. We discussed the initial pre-op investigations, selection of cases, type of IOLs, materials. Then we talked about surgical techniques and post-op alignment, misalignment, and how to deal with these cases also. I think we have some time to discuss questions. I'd like to thank the clinical board of Dr. Agarwal's group for giving me this opportunity. And this is one book we have recently come out, the Toric IOL implantation, made easy. IOL power calculation made easy for all group of cases. And this also handles the toric IOL power calculation and difficult cases also. Thank you. And I'd like to take questions if they are there.
So thank you, sir. That was A to Z of Toric IOL, sir. We learned a lot from your class. We have many questions though on the chat box also. So one of the important question is kindly elaborate the selection of K reading for the use when there is a difference in the various assessment methods. Like when you have a difference in the manual K, topo K, IOL biometric K, when there is a difference in all the values, which K to pick up for calculation?
I think that's a very good question. I think I did touched about this one. Normally, nowadays we all are, into some sort of a topographic systems which can give you a good assessment. But if possible, if you have a optical biometer which gives you a good keratometric assessment and it is calibrated, it should be a good way to begin with. But if two or three instrumentation you don't have a good alignment, so it may be because of either poor ocular surface or a patient's surface getting dry. Normally what happens, you're not getting a good reading, you keep taking multiple readings and ocular surface become much poorer. In such cases, you might put a one drop for lubricant, wait for some times, ask patient to blink twice or thrice, you might get a good reading. But best idea would be at least ask the patient to come back again with the use of lubricant drops, maybe another week or so, and reassess these patients. Even after that, you have a very variable toric corneal toricity axis, then these cases will definitely have a irregular astigmatism. astigmatism. That may be because of previous refractive surgery, or that may be because some scar in the cornea, or there may be actual ectasia happening in these patients also. In those cases, Pentacam will be a very good device to look into that, and EKR value will help you to pick up the central keratometric values, which may be important for refraction. So you look for a central 3 millimeter and 5 millimeter keratometric values, and that can be taken into consideration.
Is Rex's ruler helps in perfection of toric lenses?
I think it's a good innovative idea. Many people use this. They place this mark onto the cornea, and the mark is around, I'm not sure, 4 millimeters so, and that gives you a good orientation, because the corneal markings and the image which comes to the lens surface, there's a parallax. So you are never sure if how accurate your marking on the cornea will help you. But best would be, if you can practice yourself and use the devices like image guided, which is like again the orientation which gives you, or if you have access to a femtosecond laser device, nothing better than that. Yes, many people have perfected this aspect, making the corneal marking as a guide, and that also help you. Any sort of guide is definitely going to help you.
The next question is how to elucidate that patient has an internal astigmatism beside corneal astigmatism when cataract exists and subjective refraction is no longer accurate. That means basically how to define corneal astigmatism and lenticular astigmatism component. How do we identify preoperatively?
This question is maybe significant in a patient who is coming for a presbyopic lens exchange. That means younger patients. Because older patient, we know that whatever refraction you do is not going to be accurate in these cases. But if you can do a refraction, if the cylindrical power is different than a corneal cylinder, so we presume that there is an internal astigmatism in these cases, which may be because of lenticular changes happening in these cases. But for a cataract surgery, it is not at all important to know what is the total refraction cylinder in these cases, because we're going to correct only the corneal cylinder. That's why we are stressing on assessing the corneal toricity in a better manner, because that is one we are going to correct, because internal astigmatism is going to be as such abolished by taking out the lens in these cases. So it is important to check the corneal cylinder, and much more important in our younger patients. I
So there
think
are
this point is
instances
clear.
where we no sir, there are instances where we get a corneal topo with a minimal cylinder and an IOL biometry with more than 2 cylinders in the same patient. So how do we take it further? Like corneal cylinder comes to -1 and IOL power K reading difference comes to -3. So is it a right candidate first for toric IOL implantation, or is there a lenticular component involved in it?
Normally, biometry also doesn't take consideration of internal aberration, internal total astigmatism. It is the corneal astigmatism only which is going to be measured by the biometer. But yes, if you are taking only the anterior surface as a keratometric value, definitely it may have a different value than the total astigmatism, which is picked up by both anterior and posterior surface assessment by these biometers or tomography devices. But a refractive cylinder is totally different than the corneal cylinder, and there you can consider the lenticular astigmatism maybe a point in those cases. But Dr. Kala, the situation you are saying is very, very, may not be
Rare.
possible as such. I can understand if you are a refractive cylinder by refraction and the biometric cylinder, if doesn't match, then we can say it is an internal astigmatism, maybe a component.
Yes, sir. Thank you, sir. Should a CTR be placed in a high myope when doing a toric IOL?
I think this is a very good question. We all try in all these cases like high myos or a patient with pseudo exfoliation where you keep putting these CTRs. But it does not help you in preventing eye rotation, because it only stretches the back. It doesn't really, make lens stable. So it's not going to really help in these cases. Yes, if you have little bit of jonular weakness, like one particular area you feel there's a jonular weakness, CTR does help you in stabilizing the back. But if you have a high myopic patients, then you may have to reconsider the design of these lenses, because nowadays we can always look into the dimension of a lens, the crystal lens also, both the thickness and the diameter by doing a good OCT assessment also. So you can think of designing a lens for these cases. I remember in our days we have I think it was a big bag IOLs for a very high myopic patient, very thick and larger diameter lens. We don't have those lenses. But very high myopes, this may be a possibility that rotation may be there. But CTR as such doesn't help in these cases. We are not sure even in
Okay.
pseudo exfoliation cases also.
How early a patient can be dilated post-operatively? I think we can dilate it immediately, right?
Immediately, yes, yes. I think if you see these patients within a first hour, the pupil is still is dilated. You can see those three dots in these cases. But if you see the patient next day, so you can dilate immediately and see what is the orientation there. And dilatation is mandatory for cases where you've done a toric implantation because you want to see what is your orientation of axis in these cases. Even patient who has a 6,665 vision also, because patient might come after 3 or 4 days or 5 days where the vision would have dropped. So you know that the rotation has occurred after first day also. So it is important for all these, especially multifocal or trifocal toric lenses. You should see the patient dilatation and assess your patient. In fact, in my practice, first day we dilate the patient, we check the vision, we do a auto refraction, we dilate, do a eye trace for every patient. So we know that what was the first day outcome for these patients. Not for a checking a misalignment, but checking the outcome also in these.
Why post-operative rotation is not useful or helpful if spherical equivalent is greater than cylinder, and till when we can delay the rotation if we notice rotation?
There are 2 or 3 important issues in rotation. One is sometimes, by mistake, you have put the lens in the incorrect position. Sometimes what happens, your assistant might tell you the reference axis rather than the axis of orientation. So I require a lens of 180 degree, I place 90 degrees. So these patients, you have to rotate immediately because you can immediately correct this because it's because of your misjudgment. The lens can be fixed in the right place. But those cases where you have placed the lens in correct position, but the post-op it has rotated. That means there is some sort of misalignment between the capsular bag and your IOL. There you have to wait for at least 1 week, then go for a rotation these patients. Or patient where you feel there is a lot of viscoelastic remaining, there's a capsular bag distension, there also you have to intervene early in these cases. The other example is I have put a trifocal lens in this patient and next day patient is very unhappy because there is a residual cylinder because of rotation which is around 5 degree or more. These cases also you have to intervene early within the first few days also so that patient doesn't crip in a post-op period. But as I said, if you have a spherical equivalent more than the cylindrical, you can correct only the cylindrical portion by rotation. You can't correct the spherical power by rotation. The mismatch which happens in a spherical power is because of improper calculation of IOL power. That cannot be corrected. So if I have 3 diopter spherical and 1 diopter cylinder, I can correct 1 diopter cylinder, but 3 diopter spherical is cannot be corrected. So this patient requires a different way to handle. Either we exchange the lens because of very large dioptric, or you go for other ways. Like people do a surface, treatment with a laser. If you have around 1 diopter or 2 diopter, you can do PRK and satisfy them. Or a small bit of rotation which is happening later, you can always try, do a patch up with the laser treatment these patients. But a larger diopter of spherical areas, larger cylindrical portion, sometimes exchange may be required in these patients also.
Good, sir. Sir, one important question. In the post-operative follow-up period, see, certain centers are not equipped as AIMS. We don't have high funda missions. We have the basic mission. We don't have eye trace and everything.
We'll
Sometimes
have
the
this in
odd.
a Agarwal center in Delhi now.
Okay, sir. Nice. That's because of Dr. Jeevan Titiyal is there. So auto ref reading shows minus 1 point in the post-op follow-up. What is the criteria for the post-op follow-up? Is this the auto ref reading or the manual refraction? Or sometimes even if the auto ref shows -1 or -1.5, the patient is able to read 6.6 or the vision. Which should we follow up if we are not handling with good missions in the, we have only basic missions as set up?
The first thing is the patient's visual acuity. If the patient's visual acuity is 6 parts, so whatever may be a rotation misalignment, I am not bothered because the visual acuity is quite good. The first thing is visual acuity. If your visual acuity is not satisfactory, then only you have to do a refraction on our first day or second, third day whenever patient comes to you and dilate the pupil so that you can see those toric alignment dots. So you know that your steeper axis pre-op was 98 degree. Now this particular 3 dots in a slit lamp, there's you can see those proctors are there. If that is in 110 degree, you're sure that lens is rotated by 10 degrees, and patient vision is less than 6.9 parts or 6.9. A patient says I'm not happy. These are patients you can go on rotation. So what you have to do now, dilate the pupil completely, take the patient to slit lamp, just see where exactly those 3 marks in a slit lamp axis. So suppose this is 99 degree. Initial requirement was 90 degree. So 9 degree rotations occur. You can take this patient directly there, rotate approximately 9 degrees, the cylinder will come down. So a simple refraction will tell you your cylindrical power is much more. Take the patient and rotate, patient may be quite accurate. The simple way can be
Good.
done also. Refraction, dilate, see the how much change has happened and rotate the lens accordingly. Second time again, you have to check the what is the steeper axis, new steeper axis now, because you have done an incision, you would have changed the corneal curvature a little bit and place the lens into that steeper axis.
Okay, sir. And
Yeah.
the one more question which they have written is, which formula do you use? The IOL, suppose we go for Alcon toric site calculation, or you use the universal Barrett toric calculation site, which is much better and which is more preferable?
I think I always go by Barrett's universal formula for all these cases, and especially TK is value I take in these cases. So once you have a TK value, it gives you a both total corneal astigmatism, including both anterior and posterior assessment of these patients. And if patient undergone refractive surgery, there it is much more to have TK to be considered these, especially patient who has undergone hyperopic LASIK, where things can be
Hmm.
very difficult to assess sometimes.
Okay.
But even if you don't have these formulas also, you can very well take the Alcon toric calculator and that can be used. In fact, sometimes I do have both the calculation with me and see which is different.
Better.
If they are almost equal in the power, you are pretty safe. If they are too different, then you have to reassess your calculation. Especially if I have an actual length more than 25.5 or a 26 diopter, I have to be little careful not to have a too much of deviation happening. Actual less than 22 millimeter. Again, you have to be careful because these are beyond the normal range. There you have to be a little more careful.
Okay, sir. And how do you correct it? Like exactly a metrope or towards a little minus or a towards little plus? Which will be the best to select for a toric IOL?
I think not toric. It for any IOL, especially multifocal toric lenses, or nowadays the monofocal plus lenses. I have seen if you are towards the plus side, you make patient unhappy both distance and near. So a little
Hmm.
bit of first myopia is my cutoff for all cases, except for a one or two lenses where they ask you to go in towards the hyperopic side, especially like Technis synergy lenses where they go for a first plus side. There also I normally like to go for emmetropic power. So my cutoff is always the first myopic power in these cases, which is
Great.
give you a correct orientation. Even as patient has 0.25, 0.5 myopia, it's going to help the patient for near much more than this thing. And distance correction binocularly patient will be all right. If patient goes to hyperopic side, this patient never going to happy. So never go for a
Okay.
less than emmetropia for these patients.
Okay. And the last question, sir. Which formula do you use for post RK cases?
There, nowadays I take a Barrett's TK as such, but initially I used to go for a Haggis as one of the important formulas in a post RK patients, and Haggis L for a patient who are going to myopic classic, which gives you a much better orientation. There also it is important to have at least two or three formulas to be taken into consideration, and that should be used. So my formula has been, if I do a keratometric in a post RK patient, I'll have a three devices, maybe auto K, pentacam, and the IL master. Of that, I'll choose
Hmm.
the flattest K value for a calculation. And once I go through
Flattest
the
given.
power calculation by two or three methods, I'll take up the highest IL power which is come in these cases. The flattest K and highest IL power to be implanted for these.
Okay, sir. So that was exhaustive talk for you. I think we all have learned a lot from you. Toric IOLs, you have made such wonderful class, and it was very easy for us. Thanks for the time you have given us, sir. And we have learned a lot from this class. Thank you.
Thank you
Preeti?
both Preeti
Thank
and
you.
Kala. It was nice interacting with you, and I can see Beneath there, Beneath Malik. But whatever we do, it has to have some practical points coming up, and nice to have questions coming from our people. I hope these type of discussion will improve their you can say a practical application of managing these cases. But I'll be fighting with these, manufacturers to decrease the cost for these toric lenses.
Correct.
They should not, it's almost 3 times the normal monofocal lenses, which is not justifiable. Because now I have around 60 to 70% cases requiring toric implantation. That's mainly because we do a lot of multifocal cases, and that has enhanced the use of a toric implantation. Even for these monofocal plus lens, if you don't have a toric design, you can't fulfill this application to all the patients. So large cases require a toric IOS nowadays.
Thank you, sir.
Thank you
Thanks
so
a
much.
lot.
Yeah.